Good evening, everyone. Welcome. Thank you so much for attending this evening's MDU webinar. We really appreciate you taking your time to join us, and we've got an excellent session for you on the subject of communication in clinical practice. I'm going to start by introducing your speakers for the evening, and then we've got a little bit of housekeeping before we get on to the subject. So you can hopefully see our speaker team on screen. I'll introduce them one by one. Dr. Oliver Lord was a consultant psychiatrist before joining the MDU advisory team in 2013. He heads up our specialist team assisting members with disciplinary investigations and has a special interest also in doctors' well-being. Catherine Sheldrick is a senior solicitor in the MDU's in-house legal department, where she assists members with all sorts of really complex issues, including criminal, disciplinary, and GMC cases. And Dr. Isabel Duncan is a medico-legal advisor with a background in general practice who assists members with a wide range of medical legal matters. My name's Catherine, Dr. Catherine Wills. I'm another of the medical legal advisors, so I also advise doctors with the whole spectrum of medical legal matters. So, communication. It's an enormous subject, of course. We could probably run a weekly webinar and probably never run out of interesting discussion. But we haven't, you'll be glad to know, got all night or all week. And what we're planning to do in the next hour or so is to take a look at what happens when communication goes wrong, particularly communication during patient consultations. I'm going to spend a few minutes talking about the various medical legal processes that can flow when communication breaks down, and how we know that communication links to patient safety and patient satisfaction. Oliver's going to tell us about some pitfalls and how best to avoid them. One of the worst things that can happen to our members is when a patient alleges that a doctor's acted inappropriately during physical examination, and those allegations are usually intertwined with communication issues. Catherine's going to be telling us about some cases on that theme. And moving on from that, Isabel will be talking to us about using chaperones in practice. All our speakers will be giving some practical advice based on experience for good communication that avoids the sorts of problems we're going to be talking about. As I said, there'll be some time for questions at the end, but please do put them in the Q&A box as we go along. But please just remember not to identify any specific cases when you write your questions. Okay, I start with this multiple jeopardy slide because it illustrates that one incident can have so many repercussions for the person providing the care. And we as advisors always have this sort of list in mind when one of our members calls us up on the advice line about something that's gone wrong in their practice, or a complaint or an allegation that's been made. With apologies, I know the list is intimidating, but what it does here is give me an opportunity to just touch on a few potential sequelae of communication problems that are all probably worthy of a webinar in their own right, but which aren't really our main focus today. The red box at the top of the list is civil claim, i.e. a claim in negligence. That could involve communication allegations if, for example, a patient had an adverse outcome from a procedure or an operation and went on to allege that failure to provide proper information about risk during their consent process was the cause of the problem. We're not going to be talking about that in detail today, but there's loads of material on the MDU website about consent, about the famous Montgomery case and the relevant GMC guidance if you want to know more about that subject. Skipping right down the list for a moment to coroner's inquests and care quality commission inspections. Those are of course important again in their own right, and matters of communication are often relevant. For example, we see many cases at inquest where our members as witnesses are asked questions about how communication might or might not have broken down within a healthcare team and contributed to a sequence of events that culminated in the death of a patient. We know communication problems contribute to patient safety incidents. A recent systematic review appeared in the Annals of Internal Medicine and looked at over 40 studies which covered between them over 67,000 patients. And the authors concluded that communication problems contributed to around a quarter of patient safety incidents. And in a number of cases, poor communication was the only identified cause of a patient safety incident. I'll put the link to that study in the chat sometime before the end of the webinar in case anyone wants to follow it up. At the bottom of this list is media, which is sort of last but not least, because we know that doctors can find themselves subject to scrutiny in the media after an incident at work, for example, in the context of an inquest or a GMC case. Plus, you've probably also seen media coverage relevant to communication in public by healthcare professionals. For example, doctors whose online communications or posts have been called into question. So that's another really important aspect of communication to think about. And again, there's material on our website about that. For the remainder of this session, though, we're really focusing on communication between doctors and patients, not about consent particularly, but more, or for operations or procedures, I mean, but more broadly within consultations. And looking at that list, the middle boxes are criminal investigation, disciplinary, NHS complaints, and GMC complaints. And we'll be touching on all of those in the next few minutes. So something for those who like numbers, and there aren't many numbers here, I'm afraid, because we know that the files we see here, communication's a very common source of complaints and concerns, but there aren't too many numbers to give you. Sometimes it's a straightforward communication issue. For example, a complaint might be made about how a piece of clinical information was given, or about something not having been clearly explained, or about the manner in which a doctor spoke to a patient. Sometimes it's much more entwined with clinical complaints. For example, a complaint about a delay in diagnosis might go along with an allegation that doctors' reassurances were perceived as dismissive. Or a complaint about a procedure having been unsuccessful might go along with an allegation that the doctor made an offhand comment about it that somehow offended the patient. But apart from saying we know communication problems are a huge source of complaint, it's hard to give exact numbers. The figures on this slide are from the NHS England data on written complaints in the NHS between 2024 and 5. And these are the percentages of complaints that are logged as having arisen from matters of communication. But what we don't know is what proportion of complaints in the other categories also included an element of communication. And based on our experience, my guess is that a large proportion do. So what we can say with some confidence, even without numbers, is that in our view, communication is definitely a big source of complaints. And here on this slide are some of the communication issues that come up time and time again in complaints about our members. The one in the top box there, not feeling heard or coming away feeling dismissed, is a really big one in complaints that we see. And it chimes with recent work done by the Patients Association with Demos. That was a big report. And again, if anyone wants it, I can put the link in the chat. Around 2,000 people took part by way of polling, community conversations, and people's panels. And one of the things that was asked about was whether people had had the experience of being dismissed or not taken seriously by a healthcare professional. And a very large 38% of those with long-term health conditions said they had had that experience. There's good evidence that good quality communication is a driver of patient satisfaction, which I guess comes as no surprise. For example, in one study, over 100 outpatients with a chronic condition were asked to fill out a very comprehensive, validated questionnaire looking at a number of aspects of communication by their doctors. And there was a strong positive correlation between patient satisfaction and communication skills, things like clarity of language and how focused the patient perceived the doctor to be, and also medical information communication, i.e. how well the doctor asked things and explained things. And the other examples on there are all things we see popping up as well. But that's 7:10 now, and we've got such limited time. I think that's enough of me. So I'm going to hand over now to Oliver, Dr. Oliver Lord, for his insights and advice. Thank you, Oliver.
Thank you, Catherine. So my background is in psychiatry, and the joy of training in psychiatry is you also get trained in psychotherapy. And in psychotherapy, we talk about having a frame, and that frame also applies to any consultation, really. For a psychotherapist, you would make sure that you saw the patient at the same time of the week, every week. It'd be for the same amount of time. It'd be the same person in the same place. And what that does is create an incredibly safe place to then give away your most kind of innermost secrets. There's a huge overlap with that with just about any consultation that you have, and so that there's this sort of ritual quality to them that patients will bring, that they will have a sense that that they are able to open up in this space because it's predictable, because they know what's going to happen in there. They know how you're going to be. They know what the place is going to be like, and that allows them to undress, talk about their sexual history. They can open a box of information about themselves that they couldn't possibly do in any other way. And also, really importantly, that allows them to close that box at the end of it. They can put all those really embarrassing thoughts on the shelf somewhere. So how do we help them to keep it all contained like that? And it's about making sure that we keep that frame embedded and in mind. And so in order to meet the patient's perceptions of how this consultation should run, we need to keep that frame steady. So to meet that expectation, the place where you see them has to look like like it should with a surgery. That's very easy to do. Time, possibly slightly harder in general practice. Fair enough, you're not always going to be on time, but certainly how you behave is crucial in this. And the things that we see that upset this is being overly interested, touching them when they're not expecting to be touched, and any sort of sexual persona coming into it at all. So we almost want to have that sort of monastic old doctor sort of appearance, thinking kind of corduroy and cardigan, rather than kind of the dynamic young person that you may be. And certainly no personal beliefs coming into this, because again, that fractures that frame. So whether they are religious or political, or I think particularly around kind of global conflict has been a real source of these recently, that those are things that will crack open that frame, and so it's really important to avoid them. But trying to think about what is the patient's expectation through this, and how do they close that box at the end of it so they feel safe. I see quite a number of concerns that arise when boundaries between the patient and the doctor get breached. Now, the first thing I've put on this slide is multiple hats, and by that I mean when you are wearing several hats at once, so figuratively speaking. So when you are both their friend and their patient and their doctor, or when you're their employer. And any number of different relationships that you're trying to hold on to at once puts you in invidious situations all over the place. So if you have members of staff who are also patients, then you will know things about them that an employer shouldn't know. And once you know that, you can't unknow it. But equally, they will be thinking you're going to hold it confidential in 1 minute, but then if you're in a disciplinary conversation, another, they may be thinking, well, would we be having this conversation if they didn't know about my depression? And am I being discriminated against? So it's very easy to fall foul of those boundaries. Equally, when you have someone who is a friend and potentially becomes a better friend over time, that can create huge sorts of conflicts of interest, especially if that becomes a romantic relationship. We do see a fair trickle of files where there has been a relationship, and that is often extremely difficult to come back from. Probably more common than that, we see doctors going the extra mile. Absolutely understand why you would do that, being there, but I think a lot of people who have gone well over and beyond have also had their fingers burnt. Quite often when you do this, it's because there's something about the patient that instills in you a want to help them, something about them feels special. Quite often, that's something that's kind of psychodynamically pathological, that is actually stirring that up to push you to do that sort of thing. I think a big red flag for me is always, have I done this before? Because if it's something that you haven't done before and wouldn't do for somebody else, then check it out with a colleague. Because actually, if this is the sort of thing where the patient needs a particular letter, they need they're trying to tell you they need a particular referral or a particular medication that you haven't prescribed before and you're not entirely comfortable with, but it feels like the right thing to do because they're in such a distressing situation. Check it out with a colleague, because that grounds it again. That gets rid of the pathological dynamics that may be going on, and puts you back into that sort of cold clinical position of making the right decision for the patient. We see a number of files that relate to the doctor oversharing information, and there isn't really a huge value to the patient in you doing that, whereas it is the first step in a breach of boundaries, particularly for doctors who find themselves with allegations of relationships with patients. The first step is often oversharing, that you can end up in a situation where the patient thinks that you have a special relationship, and hence makes the allegation, even if it's not true, because they know so much about the doctor, because they have confided, particularly things that are personal marital difficulties, problems with children, those sorts of things that have no place in the treatment of the patient in front of you, but may be deeply troubling to the doctor at the time. No matter how much you trust your patient, no matter how kind of special they may be, you shouldn't be sharing that sort of personal detail with them. The last thing that kind of comes back to the frame I was talking about is probing questions. There are sometimes you do need to ask about sexual history and difficult things, but equally I see a number of complaints where it was kind of peripherally relevant at best, and it ends up sounding somewhat nosy, particularly where there's a large age gap between doctor and patient. Obviously, if questions are clinically relevant, you can go for it, but particularly around where there is a bit of pushback from the patient, a bit of why do you want to know this? Listen to that, respect that, and think, actually, is this clinically essential information to have? I see a number of cases that have gone wrong at the very beginning because in order to have rapport, the doctor overshared. And I can understand that for some people that may work, but there is a real danger in doing that you will end up with a slightly dysfunctional relationship with them that isn't doctor-patient, but more peer-to-peer. In order to get a rapport with someone, you show interest in what they're telling you. That sort of active listening, repeating back what you understand of what they've just said so that they feel heard, that's what gets you rapport. And it doesn't require any personal details from you. So as far as possible, you want to be that sort of blank screen that is there to provide medical care, but it doesn't require you to be any particular sort of personality with it. In order to get that rapport, you are showing that interest in them. Have a number of files that relate to requests from patients that didn't really want to do, but were kind of bullied into. I think the biggest area for this, and one of the most common calls we get on the advice line, is the sort of to whom it may concern letter. That I want a letter for school, I want a letter for my employer, I want a letter for court. And you're thinking, is this really my job? How do I get them out of the room? I don't really want to do it, but it sounds vaguely reasonable. Actually, for all of these letters, you can say no, unless it's a letter for the DWP. In general, you can say no to these things. If you're in any doubt, give us a ring. I'm more than happy to talk it through with you. But equally, for a lot of people in caring professions, saying no is difficult to do, and I absolutely get that. I think my best advice is what's on this slide here, is to reflect back what they're asking you for, and in doing that, give them a little bit of a warning shot that isn't going to work. So to acknowledge it with something like, I can see you're at the end of your tether, you want a letter for your solicitor, but then a warning shot that this is a difficult situation. I can only write letters about what I know, or I can see you're really struggling to find a better way through this, but I'm here to help you with your health. not with the court. So you've got that sort of warning shot there, and then a very clear, I'm afraid this is something I can't do. That means that you're getting into a patter as you go. So you're not just saying no, you're giving it a bit of an introduction, a warm-up, and by halfway through the warm-up, it's kind of obvious to the patient you're going to say no at the end of it, and makes it that little bit easier. At the end of that, coming back to agreed priorities may help. So to think that I'm here to help you with your long-term health. I don't want to be giving you another problem. If they're asking for benzodiazepines, that's a particularly good one. Or if we're talking about kind of referrals to mental health or driving problems, actually the most important thing to me is looking after your children and making sure that they're safe. And we want to make sure that if they're in the car with you, then that's all safe. So there's a procedure to go through with that. So coming back to those kind of basic things around, we want to look after your health, we want to look after the things that are important to you, like your family. And then this is the last slide from me. I also have a bit of an interest in AI. I don't know how many people on the webinar are using ambient voice technology, but it is growing. It's actually quite hard to get a handle on how many people are using it. The first thing I would always say about ambient voice technology is it should be adopted by the organization, not by the individual. So please do make sure your organization knows when you're using it. But if you are using it, these are my top tips for how to do it safely. First of all, consent around it. There's a slight debate about how much consent you actually need, but it is definitely a journey. The patient needs to know it's happening. In order to not have loads of questions about that in the consultation, there needs to be some information before they get into your room to know that the ambient scribe is going to be being used. It's important for you to know whether it records or not. For those of you not familiar with it, you may assume that they all do. Actually, they mostly don't. They mostly stream to text. So you need to know whether it does that, because that does affect whether you need to record consent in writing or not. But you'd always want to confirm that you're using it at the start and at least note any objection. They do allow for better eye contact, allow you to focus on the consultation. There's good evidence that people feel better having had ambient scribe consultations on both sides, doctor and patient, that they are easier consultations. The most important thing, though, is if you're examining a patient, you talk through the examination so that the scribe can catch it. That also means that the patient knows what you're doing, which is brilliant. For a lot of people, you'll talk through your examinations anyway, but not everyone was taught to do that. But this is a kind of a paradigm shift for that. For the scribe to catch it, you're going to have to talk them through. And then my final top tip on it is, when you're using it, you press the summarize button at the end, is go through that with the patient before they leave the room. Some consultations that might not be appropriate or safe or possible, but ideally go through it with them, especially the plan at the end. It's in the nature of these AI systems to make mistakes more frequently towards the end than at the beginning, but actually the plan is the important bit. So the dose of the medication, the kind of how many weeks till they have their follow-up, those sorts of things are going to be at the end. So recheck that with the patient. Obviously, they can go and look at it on the NHS app for most consultations afterwards anyway, but you don't want them noticing the error then. It's much easier to fix it within the consultation when you're both checking it. Okay. Right, that is everything from me. I'm going to hand over to Catherine. Thank you.
Hello, everybody. Thanks, Oliver. Catherine and Oliver have described the importance of communicating clearly with patients and ensuring that boundaries are maintained within any consultation. And what I'm going to talk about is how communication issues can lead to police investigations, and those are usually in relation to allegations of sexual assault and rape, so very serious allegations. Police investigations generally arise out of physical examinations, but those aren't limited to those that you would always consider intimate, so rectal, genital, vaginal, or breast examinations. They can often include other examinations, such as chest examinations, abdominal examinations, an examination of fundal height, examination of the eyes, and even examination of the legs. The other thing to take into account are that personal comments or behaviour, so things which might seem quite innocuous, such as fastening a zip or moving the patient's clothing, can be misconstrued by a patient and then support their concerns about an examination. There are always going to be at least two viewpoints in any consultation, and perception and memories of events differ. And those differences can be compounded where there's been insufficient communication of the purpose of an examination, what it's going to entail, and your findings. Now, having a chaperone present is obviously mandatory for an intimate examination, as you'll know, unless the patient does not consent. But the presence of a chaperone doesn't preclude a police investigation or an allegation being made. You need to remember that a chaperone is a factual witness of what's gone on in the consultation and of the examination. And so it's really important that their details are recorded at the time in the notes in case you need to identify them sometime later down the line. Some allegations come out of the blue where a patient makes a complaint directly to the police, but more often the complaint may initially be made to your employer or to a regulator, and it will be investigated by them. And subsequently, it may be referred to the police, either by the patient themselves or an employer or a regulator. Allegations can be made promptly, and that can be within a few hours or a few days, but in many cases they are made very many years later. And for example, I've had a case where they were made 40 years after the consultation. So obviously your consultation record should always be accurate and as comprehensive as possible, and that's for the patient's benefit and the benefit of colleagues reviewing your records subsequently. But their accuracy and their completeness becomes even more important when you're dealing with historic allegations, as it's very unlikely that a doctor's going to recall that consultation, and they're therefore going to be reliant on those records in order to reconstruct the consultation in accordance with also their usual practice at that time. So if the police are involved, then they are going to gather evidence, and that's usually by way of interviews with the complainant or potentially with other witnesses. And then they'll want to interview the doctor under caution at a police station. Now, normally this can be done and arranged by appointment, but there are occasions when the doctor may be arrested either in order to be taken to a police station, or alternatively when they attend at the police station. So it's important to prepare for any police interview, and I would advise that anybody in those circumstances seeks assistance as soon as possible. To illustrate some of the issues that can arise, I've put together a couple of case studies, and those amalgamate features from many different cases in which I've been involved and also my colleagues. So here in case study 1, a patient's presenting at A&E with a history of rectal bleeding. That patient had been waiting in A&E for some hours and had not been examined previously. The doctor takes a detailed history and advises the patient that they're going to need to do a digital rectal examination, and they take the patient's consent for that examination. They then go and locate a chaperone who is present for the digital rectal examination, and the doctor has made very detailed clinical notes, but unfortunately the one thing that is missing are the details of the chaperone. So the digital rectal examination is performed, the findings are noted, and they're explained to the patient, and the doctor then leaves the cubicle. That patient's then admitted onto a ward, and a week later they make a complaint of sexual assault to other staff at the hospital. and that complaint was of a non-consented vaginal examination, not a digital rectal examination. As I've explained earlier, there's no record of the chaperone, and that leads to delay in identifying who actually chaperoned the examination. And when asked, no one could remember doing so. But eventually, because this was A&E, CCTV footage was able to identify the chaperone. Now, obviously, depending on where an examination takes place, that may not be available. The doctor denied that he'd undertaken any vaginal examination, and a response was prepared with MDU assistance for the trust for the purposes of their investigation. And the patient was dissatisfied with that response and then went on to complain to the police, and there was a police investigation. If I now take you on to case study 2, this involves a new patient consultation at a GP practice. It's a patient requesting an urgent consultation, and as they're a new patient, the doctor's got no previous consultations and no sort of rapport built up with that patient. The patient presents as unwell, and the doctor's considering differential diagnoses of potentially sepsis or PE. The patient gives a history of what sounds like chest pain and describes an earlier collapse. Observations are taken which are abnormal, and a chest examination is indicated and consent obtained. Now, the chest examination to be undertaken includes listening for the apex beat, and that may have been a more thorough chest examination than the patient was either used to or had expected from the description that they were given. AVT, as Oliver's described, were being used to record the consultation, but unfortunately the summary of that consultation is not complete. Now, incomplete records can happen in any form of record keeping, whether it's computerized records, handwritten records, not just ambient scribe records. The patient's then sent to A&E, where they complain of sexual assault by their GP, which involved the touching of their breasts. No chaperone was present for that examination, and so the issue is, should one have been offered in the particular circumstances that I've described? Another issue was that the incomplete records from the ambient scribe hadn't been checked, but they'd just literally been closed. And so, again, it's really important to check any records that you make to ensure that they're complete before you move on to see the next patient. So some practical steps to remember. Obviously, firstly, take time to explain and document the purpose and extent of any examination and obtain the patient's informed consent. But also think about what examinations are clinically indicated as early as you can in a consultation, and whether or not a chaperone should be offered if they're not mandatory. Is the examination one that the patient might consider intimate, even if, as a doctor, you wouldn't think it would fall into that category? Really important next step is to document any chaperone's details, that they're there if you need to identify them at a later date. And when you have a chaperone present in an examination, make sure that they can see the examination that's being performed. I appreciate that may sound really obvious, but it isn't always, and they need to be able to see and to watch the examination. When you're completing your consultation records, please ensure that you check them before you see the next patient, because it's very unlikely, if you've closed them, that you're going to have the opportunity to come back to them and complete them later. And finally, as Oliver's described, if you're using an ambient scribe, ensure that you're familiar with how to use it as efficiently as possible so that you don't end up having to rewrite the summary that's been produced, and check that the record produced is comprehensive and complete. And finally, sometimes things do go wrong in consultations and there are issues. So it's really important that at the time you explain what's happened to the patient and that you document what happened so that that can be looked at subsequently if necessary. That's it from me. And now I'm going to hand you on to Dr. Isabel Duncan. Thank you.
Thanks very much, Catherine. And I'm following on nicely from that with some discussion around the GMC guidance on intimate examinations as well as chaperones, with a particular emphasis on communication considerations in both of these areas. I've structured these slides around the guidance that the GMC has on this. They've got a dedicated guide called Intimate Examinations and Chaperones on their website. And these first two quotes are directly from that guidance. They're paragraphs 3 and 5 and highlight some of the key principles that should underpin our practice. And Catherine has touched on this already, but a key point, the first one being that whilst intimate examinations might be routine for us as healthcare professionals, they are very rarely routine for patients. For many patients, these examinations can be embarrassing, they can be distressing, and might leave them feeling very vulnerable or exposed. I think we're all aware that there is a power imbalance inherently that exists within a lot of clinical encounters in the doctor-patient relationship, and that can be particularly amplified during intimate examinations because patients feel vulnerable, and that heightened sense of vulnerability has direct implications for how we communicate before, during, and after these examinations. Again, Catherine's covered this previously, but the GMC guidance also points out that as clinicians, our perception of intimate examinations can be quite narrow. Breast exams, PRs, vaginal, genital examinations, but patients might define intimacy much more broadly, because a lot of examinations can still require some removal of clothing or exposure of some body parts. So even if we don't consider examination intimate, a patient might experience it as such. And again, that mismatch in perception is really important. That should shape how we approach our consent and communication. So moving on to before the examination, and I would argue this is the most important part of the entire process. I think actually one of the first things to think about is this the right time to do this examination? We've briefly covered before about the common issues that we see being rushed, pressured, and that impacting on how we communicate with patients. And I think it's just important to be mindful, if you're really pressured, if you've got a waiting room full of patients and it's a really complicated patient, the history's already taken 10 minutes, you've got very limited time to do this examination, it's very, very difficult for your own pressures and stress not to transfer in how you communicate and approach that examination with patients. Commonly see complaints about feeling dismissed and rushed, as mentioned previously. Also, the examinations can be painful. And again, feeling pressured is often part of that. So there are certainly situations where you can't delay, but it might be worth considering, am I actually going to be in a better position if I move this patient to another time or day to give both me and the patient the time and space to do this examination properly and to make sure we've got enough time to cover all the things we need to before starting. If you are going to proceed there and then, this again is paraphrased from the GMC guidance and it's all points that I'm sure you'll be very aware of, but it's sometimes really difficult to remember all of it in the moment. Make sure you address any communication barriers for your patient to give informed consent to an examination. They must be able to understand what you're trying to tell them. And explaining why an examination is necessary is so important, and all parts of the examination. I think you really need to explain what it's going to involve in a practical sense. We've also talked about how patients may have had a different experience of what that examination might entail from a different clinician If there are certain things that you would normally do, you need to explain what you're planning to do. And they might not understand the rationale. Some examples might be if a patient presents with a breast lump that's very localized, they might not need to even remove much clothing for you to be able to examine it. They might be more confused about why a full breast examination might need to be done. If you take time to explain the rationale, that can help improve that trust and reduce their anxiety. Another example would be things like vaginal bleeding. Maybe that patient's already had a normal ultrasound. They might really not understand why you might want to do a speculum or take swabs. The key point's not just to perform the examination, but explain your reasoning behind each step before you're getting anywhere near doing that exam. It's also really important to warn patients if there's going to be potentially any discomfort, reassure them that they're in control throughout, and make it clear before you start that if they want you to stop, you will. And so discuss stopping the examination if they want you to. And I'm going to, again, we'll come back to chaperones shortly, but before your examination, again, make sure you're offering that patient a chaperone and documenting that they have done so, and what response the patient gave you. Clearly, you must obtain the patient's consent and record in the medical notes that the patient has given it. I think some other practical tips would be make sure that patient has privacy to undress or dress. I've certainly heard of scenarios where there's no curtain in a room, and so you can almost feel more exposed trying to undress than completing the examination. Similarly, it can be a bit infantilizing if you try to help the patient. So if they ask for it, of course do, or if you're concerned that they may struggle to get on the bed, for example, offer to help them, but otherwise let them do it themselves. And really try and minimize their exposure. Use what you can if you're in a ward, or if you're in clinic, if you've got a sheet, or if you're in general practice, use couch roll to try and minimize the amount that patient has to expose and the time that they need to be exposed for. And that leads on to preparing all your equipment in advance. It does happen that you suddenly think, I haven't got the swab I need mid-examination, got the wrong size of speculum. But if you've anticipated that beforehand and you've got everything you need, again, you're minimizing the amount of time that patient feels vulnerable, feels more exposed, which they will probably be more grateful for. So during the examination, again, we've talked a little bit about narrating, but I think that could be so helpful. Explain everything you're going to be doing before you do it. You might get occasions where patients don't want you to do that, which is fine. But I think generally that's very, very helpful. And again, explaining as you're doing, whatever you're doing, why. I think being mindful of how the patient's responding is so important. It's really easy if you're somebody who does whatever examination it is, if you do it day in, day out, it's so routine and rote to you. It's very easy to forget about the individual patient who's never had this examination before in their life and might not again, who might be finding it quite a lot. Conversely, if it's an examination you don't do very often, you might not be as comfortable or familiar with the practical nature of it. And it might be you're really quite focused on the examination and your findings. And either side, I think you can forget about the patient in the middle. Try and make sure you're picking up on their cues. Do they seem distressed and uncomfortable, even if they're not telling you that or not telling you to stop? If so, ask them. Have they got questions? Do they want you to stop? Is everything okay? And clearly stop if that examination the patient asks you to. There may even be situations where the patient is saying they're okay to carry on, but they seem really distressed, and you might choose to stop the exam. And I think that's, again, an individual decision at the time, but there might be occasions where that's necessary. Catherine mentioned this, and I would just reiterate about keeping your comments professional. If a patient's feeling particularly vulnerable and those feelings are really heightened, they might be in quite a negative headspace. And whilst you may be trying to address that tension and trying to help them by trying to lighten the atmosphere, when somebody's feeling quite anxious and quite negative, it may be more likely your comments might be inadvertently misconstrued, which is absolutely not what you want. Keep your language professional, respectful. Make sure you're using layman's terms so they can understand exactly what you're doing, but keeping it professional at all times. And this is the GMC guidance on chaperones. So it says they usually should be a healthcare professional, and you must be satisfied that that chaperone is trained for the role they're undertaking. They're familiar with the procedures involved, and as we mentioned before, they're able to stay for the whole examination. You don't want to be having your HCA or a nurse getting called off in the middle of your examination to go and do something, and they're not staying for the entire procedure, and then they aren't able to see what they're doing. So make sure that they're able to see what's going on. And again, always offer a chaperone and document that you've done this. I've got a couple of questions here, again, that are pulled from the GMC guidance. And what if the patient wants their friend as a chaperone? So by all means, the patient can bring their friend, family member for support for an intimate examination, but that person is not a trained impartial observer. They are the friend or family member of the patient. They are not a chaperone, so they can't fulfill that role. So you'd need a chaperone in addition. And what if the patient refuses a chaperone, which I think is a common question for people. And the GMC acknowledges in their guidance that this can be tricky and this can be really difficult. There may be situations in which a colleague or you feel that you feel comfortable with proceeding with whatever type of examination you're doing without a chaperone. But there may be occasions where you do not, and you feel that you need a chaperone. I think it's really important to explain to a patient what the purpose of a chaperone is. Whilst we've recognised in these talks that a chaperone has benefits for us as doctors during examinations, the GMC guidance really highlights their role for patients in terms of protecting patients' dignity, and acting as a support for the patient during examination, as well as being an impartial observer who can raise concerns if they have identified them. And I think emphasising the point that the chaperone is there for the patient and to support them can be very helpful. If you're in a situation where the patient doesn't want the chaperone and you don't feel comfortable with proceeding with the examination, you may want to consider what alternative arrangements you could make. Would a colleague be happy to see the patient, for example? Or perhaps you and a colleague together, as in another doctor, might be happy to do a joint appointment with this patient. Those are options to consider if you're in that situation. And that leads us nicely on to a Q&A.
Thank you very much, Izzy, and thank you also, Oliver and Catherine. And thanks also to all of you out there who've been putting great questions in our inbox. I'm really grateful for all of those. A lot of them are about chaperones, actually. So, Izzy, may I start by firing a couple of questions at you, please?
Cool.
There's one you sort of answered, but maybe we could go a bit further, and it's about whether a chaperone can be somebody other than a healthcare professional. So the GMC guidance said usually, is it ever okay, for example, a receptionist to act as a chaperone?
That's a great question, and I'm sure for a lot of you who are watching who might be working, for example, in general practice, it might be that healthcare assistants and nurses aren't easily available to be chaperones during appointments for intimate examinations. The GMC doesn't enforce that they should be a healthcare professional, so it says should rather than must. The reason a healthcare professional is beneficial for you is because they are likely to have their own regulatory body. For example, for a nurse being registered with the NMC, they've got their own ethical and regulatory obligations to report any concerns, whereas of course a receptionist doesn't, and particularly if, say, you're a partner, the receptionist is ultimately your employee. But if you're in a situation where that's, if you're, for example, your receptionist trained in being chaperones, you don't have any alternative, then that might be a good compromise in terms of the options you've got available to you.
Thank you. That's really helpful. There's about 100 other chaperone questions pouring in. I hope you don't mind if I fire a couple more at you. A couple of them I think you answered. They came in actually before you did your session, and I'm pretty sure they've been answered in your session. But there was one good question about, should a chaperone write in the notes? My own view is probably they don't need to, but their name needs to be recorded. Is that correct from your perspective?
I would agree that there's benefits to, and similarly, I think to the case that Catherine brought up, you really need that name in the notes, so we need to know who that chaperone is. I think if they've, there's benefits that if they've written their own version of events, particularly as Catherine mentioned, cases can come up years later down the line, and the person who is chaperoning might not have any recollection of doing so, whereas if they've written something in the notes, that may help them, but ultimately it's not mandatory for them to do so. Okay. But a really important part is make sure their name and who it was documented.
Perfect. So we must have their name, we must be able to trace them if we need them, and ideally it would be great if they could also write something in the notes. Thank you. Great question here. I've no idea what the answer to this one is. I don't know if you do from your experience, Izzy, but it's about how to explain the word chaperone if you're using an interpreter, because quite often it's mistranslated. I've really no idea. Have you got anything from your experience?
No, I've not been in that situation before where that's occurred. I think probably it goes back to the communication elements of the communication barrier and making sure that the patient's going to fully understand. So if you're worried that that's occurring, I think it might be really important to make sure that you're explaining, not just using the word chaperone, but explaining what they're there to do, why they're there, so the patient can fully understand their role.
Thank you. The other thing that occurred to me on that one is sometimes I suspect that might pop up as a problem if somebody other than a proper translator or interpreter is being used as sort of informal interpreter. So it might be better if there's difficulty with that explanation and that word, trying to use language line or whatever other resources there are for more formal interpreters. I don't know, but any other thoughts welcome in the chat, please, from the audience. Thank you, Izzy. I'll move on to a question for Catherine, if I may. And that's, thank you very much for telling us the scary stories about the police investigation. Once the police investigation's over, is that likely to be the end of it for a doctor in that situation?
It can be. Although I'd say that's less likely, because often with these types of allegations, the police will report the matter on to the GMC. So, and the GMC won't start any investigation until the police have concluded their investigation, whether that's following a trial or whether that's because they take no action and there are no charges. So it can be, but more often than not, I'm afraid we then end up with an investigation at the GMC in relation to regulatory matters around the same circumstances.
Thank you. Yes, and they're looking at rather different aspects often, aren't they, from the police investigation? Yeah, thank you.
Yeah.
And an interlinked question for Oliver, if I may. When complaints are made, maybe to the GMC or locally, we always talk about the value of sort of insight and reflection. How can doctors sort of reflect on the kinds of allegations we've been talking about?
Yeah, we see quite a lot of those sorts of cases, and quite often, obviously the original offence is denied, and so we want to be clear on factually what happened. And although there won't be any kind of sexual component to it as alleged, it is important to set out factually what was said beforehand, what was said during, what was going on during that consultation, and then to think, is there a way of doing that that would be even better than what was done at the time? And I'm always very careful that I would never want to criticize a clinician who's obviously trying their best in a busy situation, but there is often an even better way of doing it. And so to go back, read the guidance, think through factually what has happened, and think, is there something better to do? And that's what we then say, is that if I had this again, then I would offer a chaperone in those terms, and that actually if it was not a typically intimate examination, but having had this experience, I would have a lower threshold for getting a chaperone. And also to think about what the patient has said about the impact that it had on them, and to acknowledge that. It's often really difficult, because for a care worker to understand that someone else thinks that they've abused them is very, very difficult. But to understand that is at least their perception of it, and hence the impact that that's had on them, and hence to think about whether there are other changes to how they communicate that would have lessened that impact if it is true. But also, we are very much here to guide doctors through those sorts of allegations, so that is definitely not something you would be wanting to do on your own. Please come and talk to me and Catherine.
Thank you. We had a question also that I'll do my best with about recording consultations. Essentially, are patients allowed to record their consultations? Can you say no if they ask? In my view, patients are. There's nothing to stop patients recording consultations, and we should probably work on the basis that consultations are being recorded, whether we know it or not, a lot of the time, if not all of the time, with current technology. And usually that'll work in the doctor's favour, of course, because you're all doing a great professional job with nothing to hide. So I think that's the short answer to that question. I don't know if any of my colleagues have got anything to add on that one.
Yes, certainly I would assume that they are being recorded, and actually if you know that they're being recorded, you want it to be a good recording, ask them to put it on the table between you. I think audio recording is probably relatively anodyne. I think we'd worry much more about video, but the same rules, I'm afraid, apply to video. GDPR just simply doesn't apply to this. But we don't often see problems arising from this. Patients are doing this because they want to remember the good advice that you're giving them, that they're not generally doing it to try and catch you out.
Yeah, that's a very good point. And from my own experience as a patient, I know how impossible it is to remember that's everything that's said in a consultation, because as Izzy was saying, things that might seem quite routine and obvious to the doctor are usually a one-off and not at all obvious to the patient, even a patient who probably already has some knowledge, like I hope I do. So yes, do assume that people are recording things. Usually it'll be for extremely benign reasons. A couple of other points about chaperones before we finish, I think. Somebody suggested the word witness, which sounds like as a way of explaining it, which sounds like a reasonable word to use. Somebody just pointing out that in their place of work, the chaperone always makes an independent contemporaneous note. That's fantastic. I hope that's happening in most places. At the very minimum, record the identity of the chaperone in case they're not making a note and you're able to trace them afterwards. And then we've got some specific situations where chaperones may or may not be required. One of them being home visits. I don't know if any of my colleagues have got any comments about that, because doing examinations on home visits can be problematic.
I think that can be really tricky practically. Ultimately, you're still in the same position, that you need to be able to make sure you've offered. And I recognise that can be really difficult to practically be able to arrange. I think that it's about doing the best you can within the confines of the resources that you have available to you. But seeing whether, I know somebody mentioned about they're using receptionists, but they're chaperone trained, whether, if a patient wants a chaperone and you want the chaperone, that they can come with you, or whether an HCA will be able to take the time. But I appreciate it does take a lot of time out of a day in general practice, which can be a really tricky balance.
Thank you. And talking about spending time, we've just had some votes of thanks as well for an excellent set of presentations. So I'm really grateful to my colleagues, Dr. Isabel Duncan, Dr. Oliver Lord, Catherine Sheldrick, for those excellent presentations and for answering all those questions. We're dot on 8 o'clock, which is our finishing time. So I'm going to wrap up there. Thank you also to all our contributors from home with your questions and for being such an appreciative audience. We've really enjoyed the session. Thank you very much.